infectious disease specialist at the University Health System and Sinai Health System. He is pursuing his PhD in epidemiology and a specific interest in bone and joint infections.
The opportunity to talk today about some of the newer research in the treatment of, how was it his life? Bone and joint infections.
You guys here?
I have nothing to disclose about this or really anything else. I'm going to talk about some of the new research studies focusing on the research gaps that I think exist with respect to most of the treatment of osteomyelitis in the setting of diabetes, and shed light on the areas where I think the gaps are being somewhat narrowed by the recent studies, and then at the end finish with some of the areas that are probably fruitful for more research. I think I had a question, but that's okay. So with respect to areas that I think with research where we have some more new studies that help guide what we do, the first thing is what formulation would be effective. The main dichotomy always was oral versus intravenous antibiotics, and the thinking was, or the dogma was, you should use intravenous. And the other one is the duration of antibiotics that you use to treat osteomyelitis. So this is a question, a true-false question. I don't think we can answer it, but the point is that there really isn't a big difference with respect to the penetration of almost all antibiotics into the bone or synovial fluid, and so the answer is false. And so it's probably not surprising that there's more research into how we can treat these, comparing intravenous versus oral. And in the ID world, outside of HIV, we get really excited with randomized controlled trials because they almost never happen, or if they do, they're sort of less than the pilot trials for cardiology studies. But we had 1,000 patients. It's great. We didn't even know what to do with this many patients. The aptly named Aviva trial, which is oral versus intravenous antibiotics. And the only thing that the participants were randomized to is how they got the antibiotics. What they were given was the treating team, and they had to get IV or oral for 6 weeks, and then they followed them for a year, and they said who failed. And so, whoa, there's no difference. There's all about 15%, which seems frighteningly low for treatment for these infections. But nevertheless, there was no difference. So we said, great, we have evidence, we can use whatever we want, right? Well, not so fast. That's why I think it's a research area that's rapidly evolving. I think these are the important caveats of this trial. Is the infections that they included were very disparate. Someone had a spinal hardware infection, as well as someone with lower limb osteomyelitis. Those are very different diseases, but they're all included. So when you parcel out the specific infections, that 1,000 patients we were so excited about rapidly shrinks down into a small number. The other thing is we know antibiotics that are used are geographically dependent, and this was done in Europe. And so they say it was IV versus oral, but the intravenous antibiotics were typically their formulation of vancomycin, which is teicoplanin, or cephalosporins, where the oral options are largely fluoroquinolones. So really it was IV versus oral antibiotics, but it was really sort of cephalosporins and vancomycin versus fluoroquinolones. The other thing is that the surgery was performed in the vast majority of these patients. Over 90% had some type of surgical intervention. So again, it sort of whittled down again, right? It was oral versus intravenous antibiotics, specific antibiotics in the setting of some type of surgical intervention. So the next sort of area that I wanted to touch base on is the duration of antibiotics that were used for the treatment of osteomyelitis. And this is, again, can be an area that requires more research. And these are some of the newer studies that can shed light on how long these infections are treated for. So in that randomized trial, the median was around 75 weeks. So my math is not so great, but that was around 11 weeks total. And we said, wow, they're supposed to get 6 weeks of therapy, but it actually was, the randomization was they had to get 6 weeks of oral versus intravenous antibiotics, but you can do whatever you want longer than that. And you can see that they actually got almost 3 months worth of antibiotics. So at first you say, oh my goodness, that's a long time to treat somebody. There's got to be harms associated with that. But when you look, actually, this probably fits with what has been shown in the literature, with respect to the duration of treatment for these infections, which speaks to how difficult they can be to completely eradicate. There's lots of retrospective cohort studies, and these are some of the better prospective studies. You can see the small numbers of patients. This is more like the IV literature that I'm used to perusing, and they got long durations of antibiotics. So it's not to say that shorter versus longer is definitely settled. It's not to say that you need a longer course of therapy. It's just that's what's being done. And so we need much better evidence in terms of how we can treat these patients with respect to the duration. And clearly some people need longer and some people need shorter, but we have really very limited idea of what predicts who falls into each camp. So this was such a question, but it's really sort of my own thoughts on what we do. Because I see more and more of these patients where they have a calcaneal osteomyelitis and can't really do anything else. They're obviously having multimodal care and as best as possible, but we're sort of left with this, at least when I see them. These are sort of the three different approaches that I use, which is giving them an antibiotic to say, hey, if it gets worse, take this pill and call me, versus take this pill chronically, call me if it gets worse, or just call me if it gets worse and I'll see it as quickly as possible. And I use the variations of these, but I have no idea in which patient, which strategy would be more effective in. So this is an area that I think requires lots more research in, because there's really very little literature on what to do with these patients when you have recalcitrant osteomyelitis. We know in the area that I'm more interested in is prosthetic joint infections, and there we have lots of literature. Again, the caveat being it's ID literature, so it's pretty crummy overall, but nevertheless, if you give antibiotics chronically, it does work, and you give them for long periods of time, the side effects are pretty minimal. Sure beats having an ongoing infection that makes your life pretty miserable. So it does work in the setting of chronic infections. We just don't know in which patients this should be used. The last thing that I think will be much more apparent over the next little while is what predictors of treatment failure. So again, we said that there would be, we don't know how long to treat people, so I think now that we have more patients where we have data on how long we're treating them, we'll be able to identify those in whom we can use a shorter versus a longer course. The weight of the evidence right now says the absence of debridement would be the biggest predictor, but I don't know what that means. So these are some of the unmet research needs that I think require lots more research, which would be the predictors of treatment failure, the approach for chronic osteomyelitis, and then to standardize the definition of effective debridement. As someone who does infectious diseases, I've been told I'm the most aggressive surgeon there is, but I don't really know exactly what debridement means in all settings, because there's lots of patients where it's not even possible. So these are the key takeaway points that I hope you to have conveyed, and I'd be happy to take any questions. Thank you.